I'm a pediatric rheumatologist and an immunologist. I have spent most of my career at Seattle Children's Hospital at the University of Washington, serving the patients at Seattle Children's and also in the state of Alaska, and running a laboratory focused on understanding what causes autoimmune diseases like myositis, and then progressing to identify new therapies that may help patients who are still struggling despite trying multiple therapies that are available now. A few years ago, I moved to the pharmaceutical industry in order to work with the people who have all of the expertise to bring therapies from the laboratory all the way to the patients. I think that having worked with families and children for so many years really has helped me understand the challenges that they face with taking the medicines that are available, with needing to go to medical appointments for years and years, and looking at this future of never-ending medical appointments and never-ending medicines with the associated potential side effects, etc. We've made tremendous advances in science. The therapies are far better than when I started in pediatric rheumatology, 27 years ago. But we're not there yet. Patients still face a lot of side effects. The patients suppress the immune systems. They're liable to get infections. Not that many patients go into absolute remission. When I ran my lab at the University of Washington, and my patients knew that I was a researcher as well, and when I would see them in clinic, they would ask me, did you find a cure yet? Not, did you find a medicine that I can take every day for the rest of my life? They want a cure. I think that the cell therapy now is the best promise we've ever had for allowing patients to go into remission, the closest we've ever been to a cure. The CAR therapies are so promising in autoimmunity, partly because they target the same types of cells that are targeted in patients with oncology. So a cell called the B cell can cause a malignancy, can cause cancer, but the B cell can also produce autoantibodies and trigger inflammation in a patient with autoimmunity. Patients with myositis have a lot of B cells in their muscle and in their lymph nodes that are very active. These B cells in patients with myositis produce autoantibodies that we think trigger the immunity and cause this ongoing inflammation in the muscles, in the skin, even in the lungs. So the oncology doctors have developed these therapies to eliminate the B cells. And we think this will work in autoimmunity for a couple of reasons. One is because the antibodies seem to be predictive of how the patient's going to progress, how bad their disease is going to be, predictive of how they're going to respond to therapy. And we have some experience with medicines that eliminate B cells, such as rituximab. Rituximab is an antibody that targets B cells and drastically reduces the B cells in a patient. And it seems to work for some patients with myositis and other autoimmune diseases. But it only puts a fraction of patients into remission. So it really doesn't solve the problem, and it has multiple side effects. So a medicine that could really eliminate the B cells, and not just in the blood, but the B cells that are in the tissues where they're causing the inflammation in the muscle, causing that damage in the lungs. If we could have a therapy that would go into the tissues, find all those B cells and eliminate them, then that could be a much more effective therapy. So it would be like a super rituximab. And cell therapies targeting the B cells, this molecule CD19 on the B cells, seem to hold that promise. Yes, the CAR T cell therapies that everyone's heard about are developed from a cell called the T cell that comes from patients. The CAR NK cell therapies are from a different cell called a natural killer cell. So both the T cell and the natural killer cell are effective in a healthy person in protecting a patient from cancer and from viruses. So these cells are trained to go and traffic throughout the body, constantly monitoring for cells that are infected with viruses or cells that have turned into a cancer cell, and they kill it off. So natural killer cells, T cells, are very effective in the same way. For therapy, A T cell can be engineered through a CAR, the chimeric antigen receptor. So this is what targets it, what zeroes it in on a B cell, those B cells that we think are causing the disease. That same CAR can be engineered into an NK cell. And now the NK cell can zero in on those B cells and eliminate the B cells. The NK cells may provide therapy that brings cell therapy to a different level over the CAR T cells. I need to talk a little about the difference between autologous cells and allogeneic cells. Autologous cells are the cells that are engineered and CAR T cells are created from the cells of the patient himself. So the patient's cells are removed and they're engineered in the laboratory, and then those are used as the medicine. That's not possible to do with NK cells. NK cells need to be derived from allogeneic cells. So allo is a word that means different. So these are cells that are from a different person. So allogeneic cell therapy is derived from cells from a healthy person. And the cells that, the NK cells that Century is developing are even more specific in that they're all developed from a blood stem cell. So one healthy person donates blood, we isolate those cells and then create a stem cell. Now this stem cell can be engineered in multiple different ways. So we can put the CAR in, it's the same CAR that could be used for autologous CAR T cell therapy. And then we can engineer growth factors. And these may be providing an advantage in that for cell therapy, usually the patient needs to have chemotherapy first in order to make space in the patient's body for these cells to work. We can engineer stem cell derived allogeneic cells. We can engineer them so that maybe the patient won't need so much chemotherapy at the beginning. We can engineer them to be more functional by adding genes for growth factors. We can engineer in safety switches so that if the cells need to be eliminated from the patients, then we can add another medicine and the cells will be killed off immediately. We can do multiple levels of engineering in these allogeneic stem cell process. And then what's really important is to be able to expand access to cell therapies to many more people. So with autologous T cell therapy, each patient needs to have their cells engineered and what we call manufactured, so developed in the lab individually. So it requires a very specialized center. It takes a couple of weeks, although that time is getting a lot shorter. The patients need to go through this extraction process, donating the blood for the cells at the beginning. They need to go off their medications during this period so that the cells will be healthy enough to manufacture the new cells, to engineer them. And sometimes it doesn't work, either because the patient has an autoimmune disease, so their cells are not normal, or because the patient needed to take all these immunosuppressive medicines beforehand. So sometimes it doesn't work. That given, there have been a lot of success with autologous CAR T cell therapy. It works a lot of the time and is very effective. But there are these possible drawbacks, and I think the access to many more people is a huge one. So if we can start with a stem cell, engineer that, test it in the laboratory. So we've changed 5 different genes in it. We need to sequence them, make sure the gene changes went to the right places, test the lab cells in the lab, make sure that they can still kill B cells in the lab, that they have all the functions that we want in the laboratory, test them in the mouse, make sure they work well in a mouse. Then we can expand them dramatically. We can make hundreds or even thousands of doses of these cells, exactly the same in each little vial, freeze them away. Now, when a patient needs the therapy, the doctor will be able to pull a vial out of the freezer and administer it to the patient without this wait time, without needing to have to go off the medicines for so long. So we think this will create a more uniform type of medicine for patients. A major difference between how CAR T cells function in the body in a patient and CAR NK cells function in a body in a patient is the initial inflammatory response. So the CAR T cells are designed so that when they go into the body, they find the B cells and they divide, they proliferate, they produce a lot of inflammatory cytokines and can cause an inflammatory response. So there have been some patients that have fever, low blood pressure, changes in their vital signs, looks like kind of an infection. In severe cases, and this is rare in autoimmunity, patients have had mental changes. They can have confusion and even seizures. Again, very rare in autoimmune patients. Whereas the NK cells, they don't divide. They don't have this inflammatory response, and they're very short-lived. They go away within a week or so. Because that's just the kind of cells they are. Whereas the CAR T cells can live for a very long time, even months after they've been given to the patient. So for that reason, the CAR NK cells, because they don't have this, there is not this initial inflammatory response, the patients may not need to be monitored so closely in the hospital. So with CAR T cell therapy, the patients need to stay in the hospital for at least 10, 14, sometimes longer days, whereas CAR NK cells may be able to be given as outpatient therapy. And in our initial oncology trials, the patients with B-cell cancers, we've administered the Century 101 stem cell and NK cells in the outpatient clinic. The patients that are participating in the trials that are now being conducted for cell therapies across the board are patients that have moderate to severe active disease that has not responded to standard therapies. In the Calypso trial, which is the Century 101 trial of CAR NK cells, the patients may have active lupus or myositis or scleroderma. And in the case of myositis, they will have active muscle disease or lung disease, and they've tried at least 2 other medications and are just still having active disease that is problematic for the patient. The patients need to be pretty healthy otherwise, so if they have kidney disease or heart disease that would put them at risk for an experimental therapy like this, it would not be safe to enroll that patient. And then the patients will need to go off of their immunosuppressive therapies. For the Calypso trial, the patients need to be off of their therapies 1 week before the cell therapy, and that theoretically would put the patient at risk for flaring up disease. But because there is a chemotherapy dosing before the cell therapy, that covers the patient. So they go off their standard, whether it's mycophenolate or IVIG therapy, for at least a week. They get their chemotherapy, and then they get the cell therapy. The patients also need to be able to reduce their prednisone dose to at least 20 milligrams or lower 3 days before the therapy. So the patient has to be stable enough for the patient and the physician to be comfortable lowering that therapy. From the beginning, I've dedicated my work to helping young people with autoimmune diseases to live their fullest life. Through science, through developing new therapies, through understanding the disease, I think we've made great achievements, and I look forward to the next era where we may have therapies that will help patients to completely forget about their disease every day.